So my name is Dr. Sherita Golden. Today we're at the Randallstown Community Center in Randallstown, Maryland, and we're here at the Holistic Seminar on Memory Loss, which is hosted annually by the Johns Hopkins University School of Medicine. And today we were talking about the link between dementia, Alzheimer's disease, and diabetes. So because we are more adept at treating the traditional complications of diabetes, and our patients with diabetes are living longer, we're beginning to see a new complication, which is the development of Alzheimer's disease and dementia in individuals who have diabetes. And it turns out that individuals with diabetes are about twice as likely to develop dementia as those who don't have diabetes. And this is likely because of several reasons. The first is that the high blood pressure and high cholesterol that we see in the setting of diabetes can damage the blood vessels in the brain that affect our memory as well as our executive function. Another reason is because the high blood sugars in the setting of diabetes can cause alterations and damage to the neurons in our brain in the areas that control our memory. And then finally, there's a link because diabetes is associated with a deposit of amyloid, which is a protein abnormality that we see in parts of the brain that are associated with Alzheimer's disease.
If a person is 60 years old and has diabetes, why should they be concerned about Alzheimer's and dementia?
So they should be concerned about Alzheimer's and dementia if they're 60 years old and have diabetes, because if you develop dementia, then it's much harder to control and manage your diabetes. So just remembering to take your medication doses when you're supposed to, remembering to check the sugar and how to manage the diet are very complex activities. So if individuals have any type of cognitive impairment, it'll make those self-management tasks much more difficult.
Finally, if people are 40 and older and starting to see changes, what kind of symptoms should they look for to see if they have diabetes, and how can they manage to bring those risk factors down?
So if individuals are over the age of 40 and they're concerned that they may have diabetes, they should look out for symptoms like feeling really thirsty, urinating a lot, having unexplained weight loss or fatigue. All of those things could be signs or symptoms of diabetes, and they should get their blood sugar tested. So we are having some technical difficulties, so I'm going to try to keep you animated and engaged. But the handout is in your packet, and what I want to do is talk about first diabetes, and then talk about the relationship between diabetes and dementia, and then also sort of close with how having dementia can really make managing diabetes quite complicated, as you can imagine. And so I think these are important things for us to think about. So diabetes is a very prevalent condition, a significant public health burden. So about 8% of the U.S. population has diabetes. Most of that is type 2 diabetes, and I'll talk about the difference in a second. But the prevalence of diabetes increases with age. So in that first slide, you can sort of see that once you sort of hit the 65 age range, the prevalence of diabetes is quite high. And in fact, if you look among individuals over the age of 65, it's anywhere about 17 to 27% of them have diabetes. So it really affects the older population significantly. And the reason that there's been such an increase in the prevalence of diabetes is that over the years, the prevalence of obesity has risen in our country. So that second slide that really shows you the maps of the United States, the essential message is that as you move from 1990 and go over the last 20 years, you can notice that the maps, the states in the U.S. get darker and darker over time. That's showing that the prevalence of obesity has increased in the U.S., and particularly in the southeastern U.S. And then the next map is showing that as the prevalence of obesity has increased, then so has the prevalence of diabetes. So they really run in parallel. And so if we think about the risk factors for type 2 diabetes, some of them are things that are not preventable, but some of them are. So we've already talked about age being a strong risk factor for developing type 2 diabetes, particularly age over 45 years. Being overweight, we just talked about, so we'll talk a little bit. How many of you know what a body mass index is? Or you've heard that term? So it's basically your weight corrected for your height. And so what a healthy body mass index is a body mass index between about 18 and 24.9. So between 25 and 29.9 is considered overweight, and then 30 and over is considered obese. And so that's sort of a number that your doctor may tell you about. That's probably the strongest risk factor for developing diabetes, and that's one that's actually preventable. And then there are other things, so being physically inactive. So, it's very nice now that we have a computer and a GPS and our phones, and we exercise our thumbs a lot, by sliding and moving things around, but we are no longer exercising our bodies as much as we used to when we actually had to walk long distances to go places. So a lot of physical activity. Other risk factors include hypertension or having cholesterol disorders, because these diseases tend to cluster together. And then also, if you're a woman and you have a history of gestational diabetes, that's also a very strong risk factor for developing type 2 diabetes. And in fact, for women who've had gestational diabetes, they have about over 5 years, 50% likelihood of developing type 2 diabetes within 5 years, so they tend to get it at a younger age. And so what's interesting is many of you may not have been screened for gestational diabetes. They've really just started doing that in the last 25 years or so. So my mother wasn't screened. But one thing that can give you a clue is if you think back about the size of your babies, or any of them over 9 pounds. If they were over 9 pounds, I'm sure you remember that delivery really well. But the issue is that a baby over 9 pounds likely means that you could have had gestational diabetes. So like in my diabetes clinic, I ask my female patients about the size of their babies. And then the other thing that's important for our community in particular is that there are certain ethnic groups that have a very strong risk of developing type 2 diabetes. So African Americans are at very high risk, and so are the other minority populations, so Latinos, Asians, particularly South Asian individuals from like India and those places, and then Native Americans and American Indians also at very high risk. So essentially every minority group is at higher risk of developing type 2 diabetes compared to their white counterparts. So why don't we sort of start talking about what is diabetes? So we talked a little bit about risk factors, and what it is essentially is the inability to regulate your glucose, either because you don't make enough insulin or because your body doesn't respond well to the insulin that you make. And so there's two types of diabetes. So there's type 1 diabetes, which is more common in younger individuals, so typically children and young adults develop type 1 diabetes. And what happens there is there's believed to be destruction of the cells in the pancreas. The pancreas is an organ that sits in your abdomen, and it has clusters of cells that make insulin. And so when you have type 1 diabetes, for reasons that are unclear, there are these proteins that attack the cells that make that insulin. And so those individuals lose their ability to make insulin. And they usually present very acutely ill. So it's typically not subtle when this happens. But type 2 diabetes is different. So individuals are still making insulin, but it's just that they're not making enough insulin, and the insulin they make, their body's not responding to it well. So the organs that really help us manage our glucose are our liver. So if your glucose is high, like after you eat a meal, then what your liver will do is make sure you have enough insulin, and it'll actually shut down making glucose on its own. Your liver can make glucose on its own because it stores it there. But if your glucose is already high, your liver will stop making glucose. And the other organ that's important for regulating your glucose are your muscle cells. So what the insulin does is it helps take the glucose out of the blood and take it into your muscle to build protein and to do other things. But what happens when you have type 2 diabetes is that even though you're making insulin, your muscles don't respond to it well, so your glucose sort of stays in the blood even though your insulin level's high. And then your liver will still keep making glucose even though you already have enough. And we call that term insulin resistance. Have any of you heard that term insulin resistance before? So that's essentially what that is. And so what I'm basically showing you in that picture that's on the slide is just how the liver and the pancreas are sort of interacting together to regulate glucose, and that's dysfunctional in the setting of type 2 diabetes. And so what the picture is showing, for those of you who are visual, is that there are receptors on the cells, and that's shown in this slide here, that there are actually receptors on your cells, so on your muscle cells, on your fat cells, on your liver cells that are sort of telling your body to move that glucose into those cells. And what happens in the setting of insulin resistance is those receptors do not respond, so the glucose just stays out in the blood. And that's often when you get diagnosed, because your doctor will pick up the high glucose levels in the blood. So is that all clear? So we really have insulin resistance at the level of our liver, at the level of our muscles. Even our fat cells don't respond to insulin as well. And so all of that contributes to insulin resistance. So what about, sort of what can we do to sort of like manage and sort of prevent the onset of diabetes? And before we talk about that, I just want to review the symptoms. The symptoms of diabetes might be later in the handout, but since I don't have the slides, I suddenly can't remember. So I'm going to talk about that. And this is a dementia seminar. That's kind of sad. So my son told me I forget things because I'm getting older, and I told him it's because my brain is actually full. So something has to come out for new information to come in. But let's talk about the symptoms of diabetes. So they're typically things like feeling really thirsty, urinating a lot. And when I say urinating a lot, I mean like every hour. Often patients describe that they're getting up every hour through the night to go to the bathroom, and they're dying of thirst, so they'll keep drinking, but then they keep going to the bathroom. And often before people figure out what's going on, they may drink things like Coke or other things that have more sugar, and then that makes it worse. So feeling really thirsty, urinating a lot, like every hour, not able to get through the night without going to the bathroom several times. And then the other thing can be blurred vision, because what happens is when the sugar is high, it distorts the lens of your eye, and so your vision becomes blurred. So that'll often send people to the eye doctor because they're concerned that the vision's blurred. So sometimes your eye doctor or the ophthalmologist picks this up. The other thing that can happen is that you can sometimes also have weight loss. So people will be very excited that they're losing weight, but you only want to be losing weight for the right reason. So the reason that people lose weight is if your body and your cells can't use glucose, then what it'll do is it'll start breaking down fat to try to get energy, for your body to continue to function, and that, along with the urinating a lot, can cause weight loss. And then often, people feel fatigued. So you can imagine if you're supposed to be using this glucose for energy, but your cells don't have energy, people feel extremely fatigued. So those are often the signs and symptoms. But what's kind of frightening is that a lot of times diabetes can be completely asymptomatic. And so individuals can have high glucose for a number of years without symptoms and not even know. So that's why it's really important if you have a family history of diabetes, you're a high-risk minority group, you've had gestational diabetes, you're overweight or obese, you want to make sure your doctor's screening you for diabetes at least on an annual basis. So let's talk about what we can do about diabetes, from either to prevent diabetes or to treat it once you have it. So one area is nutrition. So nutrition is a very important area. We all like to eat. A lot of our church fellowships are centered around food. And so we have to really think about what is the nature of that food and how can we still have fellowship and make it healthier. So one of the things, is reducing calories. So I recommend to anyone who has diabetes to go and see a nutritionist, because you're often eating more than you think you are. Because if you actually look at the food portion models and see what a serving of like mashed potatoes or rice are, you'll be utterly amazed at how small it is. So I think that our portion sizes in general have gotten much larger, so this is something we need to think about. Really eating smaller meals spread throughout the day is better than eating like several large meals. A lot of patients think it's better, I'm going to skip breakfast and lunch and then I'm just going to eat like this humongous dinner and then I'm going to go to bed. So if you actually eat your largest meal late in the day like that, and then you go to bed, you're not even burning those calories, so that can contribute to obesity. It's really eating smaller meals spread throughout the day, and then decreasing the saturated fat. So saturated fat are in good things like hamburger, steak, whole milk, cheeses. So really trying to get the low-fat varieties, the leanest meat that you can. Eating like chicken and fish as opposed to the red meat, all of that will help to lower saturated fat. And then also, sort of increasing your intake of monounsaturated fat. So those are good fats. So those are in things like nuts, and if you're cooking things like canola oil, safflower oil, olive oil, not the lard. My grandmother used to bring a bucket of lard up from the basement. She's like, honey, go get me my lard so I can fry the chicken. Very high saturated fat, and you can tell saturated from monounsaturated fat because saturated fat is really thick and hard, where in your monounsaturated fat is like oily and liquid still, so that sort of gives you an idea. So if you fry something and then you sit it on the counter and it gets like real hard on the top, probably you've generated some saturated fat. So that sort of just gives you an idea of how you can tell the difference. And then the other thing is, when my son was in elementary school, we had a campaign called, Keep It Alive with 5. So they wanted to make sure the kids got 5 servings of fresh fruits and vegetables a day. And that also works for individuals with diabetes. So, fresh fruits and vegetables. A lot of patients will say they can't eat fruit because it has sugar. But, honestly, bread has sugar. Donuts clearly have sugar. So people tell me, I can't eat apples, my sugar goes way up, but then you see them at Dunkin' Donuts. I would much rather, I would much rather have somebody eat fruit because it also has fiber. So when you eat something with fiber, it doesn't raise your sugar as much as it would if you didn't have fiber. So 5 servings of fruits and vegetables is still, appropriate. So like your orange juice in the morning, like 4 ounces, that counts as like one of your servings of fruits and vegetables. So when we say 1 serving, we're talking about around 15 grams of carbohydrate. And so your nutritionist can sort of sit down with you and go over that. And then the vegetables, most of the vegetables don't really affect your blood sugar at all. So vegetables are really good, your salads and things like that. So, any questions about diet before we move on to physical activity? Yes? Beans? Yeah, so beans are good. So the question is, what about beans? So adding beans to your salad are good because beans have protein in them. And so beans are good for protein. They do have some carbohydrates, so you have to be careful about the amount, but they're good for protein. So, yes, one more diet question. To lower phosphorus? Is it phosphorus or is it potassium? Do you know which one? Okay. Yeah, so phosphorus will be in things like some of your like milk products or things like that. So, it'll be in some of your dairy products. Yeah. So why don't we talk about physical activity? So I have a very funny picture of this, this gentleman walking his dog. So one of my colleagues gave me this picture. So obviously neither the dog nor the man are getting very much exercise in this picture. But exercise is important for a variety of reasons. So it really helps with stress reduction. So just, when I was driving over, I saw a lot of people walking out in the neighborhood. So a good morning like this, like 30 minutes of just brisk walking about 3 to 5 days a week is excellent exercise. Exercise is important because it also, in addition to lowering blood sugar, lowers blood cholesterol levels and blood pressure. So you're really getting everything at one time. And it also lowers your sugar for several hours after you walk. So, exercise is good for improving your ability to lose weight, but even separate from that, it makes your cells, like your muscles, use insulin better. So your sugar will tend to drop for several hours after exercise. So it's very beneficial. So I recommend that people start with just brisk walking, 3 to 5 days a week for 30 minutes and then work up from there. Join a fitness center if you have access to do so. I think the community center here in Randallstown is fabulous. Like there's a pool, there's a walking track inside. Like we're jealous in Reisterstown, we don't have one of those. That's really important. If you wear a pedometer, do any of you have a pedometer? It's this little, so it's this little instrument that you clip on your waist and it measures the number of steps you walk in a day. So the goal is to really try to get up to about 10,000 steps a day. About 2,000 to 2,500 steps is a mile, just to give you some idea. And so even if you're just like doing housework and you're going up and down the stairs with the laundry, you're running errands, like all those steps count toward your physical activity. And what's nice about the pedometer is if you have a desk job, you can look down and see, oh, it's 5 o'clock, I've only done about 3,000 steps. So when I go home, I'm going to walk, I'm going to make sure I'm up and down the stairs. So it helps you to keep track of what you're doing. And then the other thing is if there are any shopping malls that you live near, usually first thing in the morning, a lot of the malls are open before the stores open and you can really get some good walking activity in that way. That's helpful, particularly in the winter months when we have a winter like we just had. And then also if you have problems with your feet and your hips, even doing arm exercises and upper body exercises can be really beneficial for your heart as well. So just any type of physical activity and movement is going to be beneficial. So really that's like the core of our treatment for diabetes is the physical activity and the diet changes. We call that all healthy lifestyle change. And then there's also a series of medications that we use to treat diabetes. And I'm not going to go through them all in detail. I just want you all to have that information so you can have an intelligent dialogue with your doctor. Because when I started medical school in 1990, there were really just insulin and one class of pills. There was really nothing else. And it's been utterly amazing to me how now we have a whole arsenal of drugs, pills, different kinds of insulin, non-insulin injectable medications, all that can be used to treat diabetes. And the right one for you really depends upon what other health conditions you have and sort of what your other personal goals are. Because some of them are associated with weight loss, some can be associated with weight gain. So it's really important to have a dialogue with your doctor about them. But I think the point is that, what's interesting about the medications is they all target different aspects of what goes wrong in diabetes. So there's a whole set of drugs that help your body use insulin better. They're called insulin sensitizers. There's a set of drugs that help your pancreas squeeze out a little bit more insulin. Those are called insulin secretagogues. And then there are other drugs that replace some of the hormones in your gut that normally are released after you eat. But when you have diabetes, they're low. And so there's a whole set of drugs that replace those as well. So we have a lot of different ways to treat diabetes now. And I just want to say a word about the insulin. I think at least 2 people that I saw in clinic yesterday were like, I am doing everything I can to avoid insulin. I'm like, surprise, surprise, so is everybody else that comes to my clinic. However, the point I want to make with insulin is you should not feel like if you need to use insulin that somehow you have failed or reached the end of the road. What happens is the natural history of type 2 diabetes is that over time, your body becomes less and less responsive to the pills. So some people end up needing insulin. And really the way that I look at insulin is really like you should use whatever means necessary to keep the sugar low to prevent the complications of diabetes, whether that's pills, insulin, a combination. And we'll talk about the complications. So don't look at insulin as your enemy. Insulin is actually an important part of the armamentarium of what we can do to really combat this disease and prevent the complications. So I want to talk a bit about monitoring your diabetes before we go on to complications. So one of the ways you do that is doing those finger stick blood sugar checks with the glucose meter. But the other way that your doctor often monitors by checking something called the hemoglobin A1c. So how many of you have heard of the hemoglobin A1c? Okay, so good. So this is a number you should ask your doctor. If you have diabetes, ask him or her what it is. They should tell you what it is so you know. And so what the hemoglobin A1c does is it measures how much glucose has been floating around in your blood over 3 months. And so what happens is that the glucose binds to your red blood cells, and normally in our blood we have about 4 to 6% of our red blood cells have glucose attached. But when you have diabetes, you have more and more, a higher percentage of those red cells with glucose attached. So when you have 6.5% of your cells with glucose attached, that sort of tells you that you have diabetes. And then once you have diabetes, your doctor will monitor that number, because we know if that number is 7% or lower, that significantly reduces your risk of complications. So that's why your doctor is always monitoring that number. And there's a chart on your handout, and it shows you, based on your hemoglobin A1c, what your average glucose is. So this chart is helpful because if you're checking your sugars at home and you're getting 250 readings on a consistent basis, every day, then your hemoglobin A1c may end up being around 10% by the time you go back to the doctor. So don't wait 3 months to go and see what it is. You should call and let him or her know. I've been noticing this pattern of higher sugars, so they can make an adjustment in between your visit. So now we're going to move on so we can talk about what our goals are. So we talked about we want the hemoglobin A1c less than 7%. We want the glucoses that you check with your meter to be between 90 and 130, so that gives you some target idea. And then if you check your glucose 2 hours after meals, you want it to be less than 180. Okay, so just so you sort of have those numbers in your mind. And so then what are the complications of diabetes? And so this is really the whole reason that we care about how high the sugar is because we want to prevent all of these complications. And the good news that I can also share is it's interesting having had my whole medical career parallel what's happened in diabetes over about a 20 or 25 year period. When I was a medical student, it was not uncommon for me to see patients with diabetes that had every complication. They had lost their vision, they'd had an amputation, they'd already had a heart attack, they were on dialysis. The very first patient I saw, in fact, I remember him to this day, was a 31-year-old young man. So he was younger than I was, or just a little bit older than I was at the time. And he had had a kidney transplant. He had type 1 diabetes since he was a child. He'd had a kidney transplant, so that's why he was in the hosptal. He'd lost vision in one eye. and he'd already lost a couple of toes, and he was 31 years old. Now the good news is I can tell you I rarely see that today, which is a blessing. So in 1993, there was a big study published called the Diabetes Control and Complications Trial. And what it showed that if we tightly control blood sugar in people with type 1 diabetes and get that hemoglobin A1c to less than 7, we could prevent all of those complications. So that totally revolutionized the care of diabetes. That was part of the reason I went into it, actually, because I realized we could really help people. And then there was another study published in 1998, so a few years later, in patients with type 2 diabetes that essentially showed the same thing. If we get that hemoglobin A1c down to 7%, we can prevent complications in type 2 diabetes as well. So that has completely changed how we manage diabetes over the last several years. And there was a study published in the New England Journal of Medicine earlier this year, and what they've shown is that over 20 years there's been a decline in eye damage, kidney damage, all of the complications. So I think it's really, we've really been able to combat this disease, so it no longer has to get you. That's the encouraging message. So what are the complications? So the common ones are what's called nephropathy or kidney disease. So diabetes affects small vessels and large vessels. And I'll come back to that when we talk about dementia in a few minutes. So the small vessel diseases are the kidney, that's called nephropathy. And if untreated, that's what leads to dialysis. Then there's the eye, so that's called retinopathy, and that's what can lead to blindness if untreated. And then it also affects the nerve, so that's called neuropathy. So that can cause that numbness and tingling and burning that individuals sometimes get in their feet. And if untreated, it can lead to amputations because people might step on things or not feel things and develop an ulcer. So those are all the things that we want to prevent. So, sort of the important preventive things. So for the kidney disease, your doctor should be checking your urine protein every year because we can sort of pick it up early, and then we can intervene by making sure the glucose is controlled and making sure the blood pressure is well controlled with certain medicines. And then in terms of preventing the retinopathy, every patient with diabetes should have their eyes dilated and examined every year by an ophthalmologist. So not just the optometrist. The optometrist fits your lenses for your eyeglasses, but the ophthalmologist is a person that puts the drops in your eyes and looks in the back. So you'll know you've gone to an ophthalmologist because when you leave, you can't see for many hours because they dilate your eyes, and then you're driving around and all the stop signs look like stars. That's how you know you've been to an ophthalmologist. But they really need to look in the back. What they're looking for are damage to the vessels. The earlier they see that, the earlier they can intervene with laser surgery and prevent people from losing their vision. So another evidence-based treatment. And then for our feet, it's really important for patients with diabetes to check their feet daily. Just look at them and make sure you don't see anything, an ingrown toenail, fungus, that you stepped on something you didn't know about. If you have calluses, you want to really go and see a podiatrist, not the pedicure lady. That's not, you can go to her to paint your toenails after you've been to the podiatrist, because you really want the podiatrist trimming your calluses, any ingrown toenails, because a manicurist is not really licensed to do what a podiatrist is if you have diabetes. So that's really an important thing to remember. And then you don't want to do what my grandmother used to do. She used to just put her foot up and take a knife and start trimming. She didn't have diabetes. I wouldn't have let her do it otherwise. But you don't do any self-care with the feet. This is something you really want a professional to deal with. So let's move on to talk about the large vessel complications of diabetes. So that's heart disease and then also stroke. And then the stroke is actually part of what's connected to the link between diabetes and dementia. So most of the heart deaths in diabetes occur because of heart disease. So that's the most common cause of death. So most patients are very worried about losing their vision or going on dialysis, but really the most prevalent complication is really heart disease. And so most of the hospital admissions for diabetes are due to heart disease, so this is really an important complication. And what's interesting is that there's studies showing that if you have diabetes and you've never had a heart attack, your risk of having a heart attack is the same as someone who doesn't have diabetes but has already had a heart attack. So in other words, just having diabetes alone to your heart is almost like having had a heart attack already. So that's why we're very aggressive with prevention, sort of making sure your cholesterol is adequately treated. Your doctor might want to put you on a group of medicines called statin drugs. They help to lower your cholesterol. Treating blood pressure aggressively is very important for preventing heart disease. Stopping smoking, very important. The best thing you can do if you have diabetes and you're smoking is to stop. for a variety of reasons, but particularly for preventing heart disease. The other thing smoking does is it damages the blood vessels in the leg, and that can also contribute to amputation. So anything like that you want to stop. And then what I'll say about the complications of diabetes is that the eye disease, the kidney disease is much more prevalent in African Americans than it is in the majority population. Some of that has been in the past, related to our access to health care, but it's also because we tend to have higher blood pressure. Hypertension is very prevalent in the African American community. So we need to not think about these things lightly. They're sort of called, hypertension is called the silent killer for a reason, because you don't really feel when your blood pressure is high, and often you don't feel when your glucose is high either. But yet those things are could potentially be damaging your kidneys, your eyes, your heart vessels. So you just want to really be aggressive and not take any of that lightly, because all of this can be prevented. So then how is diabetes related to dementia? So it's very interesting that it turns out that the risk of developing dementia is about 2 times higher if you have diabetes compared to not having diabetes. And there's been a lot of research. So really, this is what I consider a novel complication of diabetes. Because I mentioned when I was in medical school, people were dying from the other complications very frequently. But now that we've sort of learned how to prevent those other complications, people with diabetes are living much longer. I mean, I have a patient who's 101. And so people are living longer. So now we're seeing a whole nother set of complications that we probably didn't see before because people died at a younger age. So now we're seeing dementia and cognitive impairment as complications of type 2 diabetes. And really, there's like several reasons that these may occur. And there's like a little diagram that I have in your handout. So one is that we talked about the fact that diabetes is related to high blood pressure. So high blood pressure can damage the blood vessels in your brain just like they do in the heart, and that can lead to little mini strokes. And so if you actually have strokes in those areas of the brain that affect your memory and your executive function, your ability to do things, then that can actually contribute to dementia. So some of it is related to where do these strokes occur, but then there's also some data recently suggesting that diabetes can be associated with those amyloid deposits in the brain that are associated with Alzheimer's disease. So I'm sure our previous speaker probably spoke about that, but there are these amyloid deposits in particular areas of the brain that control memory and cognition, and so that is also associated with diabetes. So it's really probably a combination of these small vessels in the brain that get damaged, as well as the amyloid that's depositing in the brain that gets damaged. And another thing that's intriguing, and again, we're doing research to try to understand this, is that when you have high glucose levels in the setting of diabetes, the high glucose levels itself can actually cause damage to certain parts of the brain that control your memory and your cognition. So it's really a combination of the blood pressure damaging the vessels, the high glucose, damaging those nerve cells, and then the fact that the diabetes is associated with deposit of amyloid. And so what we're not certain about yet is if we treat diabetes aggressively, can that help to sort of prevent the cognitive decline and the progression to dementia? And there are actually a couple of clinical trials that are underway right now to answer those very questions. And I think we also need to understand which individuals are at risk of that happening, because a lot of individuals with diabetes don't get any cognitive impairment, whereas others do. So how do we, identify, who's going to be at risk for having that happen? But the reason I think this is important is because we ask patients with diabetes to do a lot of complex self-management. So you're checking your sugar. Sometimes you're adjusting your insulin based on what the blood sugar level is. Be aware of the carbohydrates you eat. Go and exercise. So if you think about going to exercise, it actually involves a lot of brain executive function. So you have to figure out, when am I going to exercise? How am I going to get there? I've got to make sure I have the right walking shoes on. All of those things. So you can imagine if you start to have cognitive impairment, so I don't remember how to get to the gym, where are my shoes, I don't remember how to check my insulin, so suddenly they have to check their glucose and then they have to dose their insulin based on a sugar. You can imagine if somebody's having problem with memory and understanding that they might actually be at risk of doing some harm to themselves potentially, because this is all very complicated. And so sometimes in my older patients, I'll just ask them to show me what they do. I mean, one of my patients, I couldn't understand why her hemoglobin A1c was still 10%. We kept going up on the insulin. It was very confusing. And I said, well, show me what you do when you give yourself your insulin. So, she sort of went digging in her purse and she pulled out this pen. And I said, well, have you been putting a needle on it? She was like, oh, wait. And she's just digging down her purse to find the needle. But she essentially had been injecting, but like not putting the needle on the end. So that was the first clue to me. I was like, oh, we sort of have a problem here. So, so if you have a family member and, just sort of ask them, show me what you do when you check your sugar. Show me what you do when you're fixing your meal. Because if just having them show you, you can sort of begin to pick up whether or not you notice that there are issues related to cognitive impairment, because this is a very complicated disease to manage, and so it's very difficult to do if you are unable to manage your medications and manage your lifestyle. And then obviously all of those things, if mismanaged, can then increase the risk of complications, which can make things even more difficult to manage in the setting of dementia. So those are sort of the things that we think are linked. There have been some studies to show that people who use insulin maybe have a higher risk of developing dementia, but we don't think it's the insulin. We think it's the fact that they are just probably have more severe diabetes, and that's the link. Because there are other studies to show that if you give inhaled insulin, so if you inhale insulin through your nose, it can get directly into the brain, and that actually results in improvement in cognitive function and memory. So that's some very recent work that's been going on. So we think insulin plays an important role, and it may be that same insulin resistance that's at the level of the muscle in diabetes, there may be some insulin resistance in the brain. And so we're really sort of working on novel ways to figure out how to overcome that in the brain. So I think that is most of what I had to say, and actually on the last page is actually the contact information for the American Diabetes Association. There's a lot of excellent information on their website. And there's also, the Maryland affiliate is right downtown on Alpha Falls Road, down in the city. So we have a very active group there. And the first, actually, I'll make a plug for this since I'm here. So the first Sunday in October is going to be the Walk for Diabetes in the Baltimore area. And so that's where they raise money for both type 1 and type 2 diabetes. So I know our Hopkins team will be working on pulling together a team, but we hope some of you will come out as well, because this is definitely a preventable condition, and the complications, even the dementia, are likely preventable if we treat it well. So I'll be happy to take any questions. Yes?
About whether it's better to eat raw vegetables, juiced vegetables, and what do you think about dried fruits?
So the question is it better to eat mixed raw vegetables, juiced vegetables, and what about dried fruit? So raw is somewhat the best kind because we haven't done anything to it. But for obvious reasons, people may or may not be able to eat raw vegetables. So steaming vegetables is good also, because when you steam them, you don't bake all of the, you don't sort of leach out all the vitamins. Like my grandmother used to cook cabbage to death to the point where it was brown. We all remember brown cabbage, right? So we don't do that anymore. But steaming vegetables, and then juicing is good too. Juicing the vegetables is good as well. And then, dried fruit, just being aware of the portions, but dried fruit is good as well. Because anything that you do other than like steaming or drying, if you start overcooking, like if the vegetables look wilted at the end, that's a sign you've overcooked. I mean, that's been an adjustment. I mean, I've had to adjust to that over the years. And if you want to cook with a little seasoning, like you're trying to do a turkey bone instead of a fat back, things like that. But really, like the steaming is good, and juicing and raw, and the dried fruit is fine. But if you're doing dried fruit, just still be aware of the amount, because even too much of even good things can still make your sugar go up. So just be aware of the amount. Yes. What's, yeah, so her question was, what about inhaled insulin, and is that still being studied? So most of the inhaled insulin products have been taken off of the market because they weren't really very I don't think there was any harm associated with them, but it's just because they just weren't really being utilized that much. Because, you know, they could manage the short-acting, like it replaced your short-acting insulin, but people still needed to take a shot of long-acting insulin. So I had a lot of patients that thought, well, if I still got to take a shot, I may as well just keep taking a shot. So most of those products are not currently still on the market. Yes. So the question is, what's the relationship between high cholesterol and diabetes and dementia? So it's not uncommon in diabetes to have high cholesterol as well. And typically, you know, there's several components to your cholesterol. So there's triglycerides, which are the fat part of the cholesterol. And then there's your HDL, which is your good cholesterol. And then there's LDL, which is the bad cholesterol. So in people with diabetes, their triglycerides are often high, and then their HDL or good cholesterol is often low. And so that particular cholesterol pattern is associated with more damage to blood vessels. So that's why you can get the heart vessel damage and then also the blood vessel damage in the brain. So again, if you're getting that damage to the vessels in the brain, that could be related to the dementia, depending upon where that occurs. So, so that's typically the link there. Yes, there's a question here, and then we'll go around.
Coconut oil. There have been recent studies that it's good for you versus olive oil and vegetable oil.
Right, so this was a question about coconut oil being better for you than the vegetable oils. And so, so coconut oil, I believe, has monounsaturated fat as well. I'm not aware of as much of the research with coconut oil as with the vegetable oils, so I can't comment on that as much. But again, like, you know, looking at the oil, I think if it looks like it's a clear oil, that's going to have more monounsaturated fat in it, which is the good fat compared to the thicker oils. But I'm not as aware of the comparison with the vegetable oil. I think there was a question here, and then we'll go around. Yes. For diabetes. Yeah, so this is a very good question, something we should talk about. So that she was commenting on a study with Lipitor. So Lipitor is one of those statin medicines I talked about earlier that it's been associated with an increased risk of diabetes. So there are some what we call epidemiology studies that show that people who took Lipitor had a higher risk of developing diabetes. And so those are like association studies. So they sort of suggest there may be an association, but they can't really tell us if that's the real cause or not. And so essentially, because heart disease is really leading cause of death in people with diabetes, and even it's a leading cause of death in the population as a whole, you know, sort of the providers feel that the risk of diabetes is small enough that it doesn't warrant not taking those drugs, because the risk of heart disease is so high if someone needs them and doesn't take them. So there's still ongoing work about that, but it's unclear if it's really the statin drug, or is it that people who go on those drugs maybe have pre-diabetes and were at risk anyway. So there's a lot of sort of issues that need to be sorted out with that. But we certainly have not been stopping them in people who have diabetes. And if someone does not have diabetes but has a high risk of heart disease, we're still using those drugs because we know that they'll prevent the heart disease. But it's an area where there needs to be more work. Yes, I think there's a question here, and then I'm sorry. Right, so this is good too. So what does pre-diabetes actually mean? So this is what doctors used to call a touch of sugar or borderline. Like, I hate that. So like, nobody touched anybody with sugar. I used to hate that. I hate that. So there is a term called pre-diabetes. And so with pre-diabetes, you know, if you have diabetes, then your fasting sugar is over like 126 or higher, and your hemoglobin A1c is 6.5% or higher. If you have pre-diabetes, you have a sugar between 100 and 125, and your hemoglobin A1c is between 5.7 and 6.4. And in that pre-diabetes phase, you know, what that means is that you have a high risk of developing type 2 diabetes. That's the phase where you really want to work on your exercise, your diet modification, and weight loss to prevent the progression. Because we know if we intervene at that stage, we can prevent progression. So if your doctor says you have a touch of diabetes, don't worry about it, you should be concerned. Don't also let them give you a false sense of security. That is a point at which you can intervene and prevent it. So what often happens is patients are told they have pre-diabetes, the physician downplays it, And so then they just think they don't need to be concerned, and then they come to see someone like me 2 or 3 years later because now they actually have diabetes. Where if we had all interacted at the pre-diabetes phase, we could have implemented things to prevent that. So that's what that means, and I consider that a real condition. It's not a touch of sugar, there's no borderline. Either you have it or you don't. So just don't let, they use that with our folks. That's why I'm telling you these things. Like, it's a real opportunity for intervention. So I'm going to go in the back. There's a couple of people back here that were waiting. Mm-hmm. Okay, so this is a good question too. Yeah, so are there studies to show that if you had diabetes and you were on medication that you could go off of your medication, or if you had diabetes, perhaps you could revert back to not having diabetes? That's the question. So, so definitely with weight loss, if someone's diagnosed with diabetes and they start medication and then they start exercising and lose weight, it's not uncommon that they can decrease the amount of medicine that they're taking. So often about a 10 to 15 pound weight loss is enough so often people feel like, well, I need to lose 30 or 40 pounds, but just that first 10 to 15 pounds can help improve your body's sensitivity to insulin, help you be able to reduce some of your medication. So, well, we have studies that show that. And the other setting where people have actually been able to revert back from diabetes is a significant amount of weight loss. So either through like lifestyle change like we talked about, or recently there are studies coming out when patients undergo bariatric surgery where you can lose a significant amount of weight, 50 or 80 pounds. Those individuals can go off medicine completely and revert back. So that's not for everybody, but those are sort of the settings where you can really go off medication completely, is with a really significant amount of weight loss. So those are sort of the settings where that can happen. So yes, Sister Neptune, I think you had a question. Wait, let me come back so I can hear. Mm-hmm. Right, so this is another very good question. So is Actos still on the market? So on your medication list, there's, remember I talked to you about the insulin sensitizers? So one group of insulin sensitizers are metformin, and then the other are these class of medicines called thiazolidine diones. And one of them was Actos and another was Avandia. So you may have remembered years ago there was an issue with Avandia causing more heart attacks. And so, so that one has not been taken off the market, but there's so many black box warnings that I've never prescribed it again. I just sort of felt like there were enough uncertainty that I had stopped. And then so Actos is in that same family. It is still on the market. I personally don't prescribe that anymore because there's often other complications that can cause fluid retention and weight gain, and there's a question about whether it may be linked to bladder cancer. So those are some of the concerns that have come up. So it's still on the market, but it's more like a third line, agent as opposed to being one that people would use earlier. So this, it's still on the market, but again, these are conversations you should have with your doctor. So the purpose of forum like this are to inform you so that you can make an informed decision. Yes. Mm-hmm. Right, so her question was, how can you talk to your doctors about herbal medicine? So you are correct. Most of us are uncertain. I have no idea because we didn't really learn about that in medical school. I mean, I'm just going to be very honest, most physicians trained in the traditional medical system just haven't been trained to sort of really know and understand which agents are most useful, which ones are beneficial, which ones might be harmful. So there's actually a whole class of research now. It's called complementary and alternative medicine, where there are actually research studies to study some of these alternative treatments so that we can really begin to understand which ones are effective and know which ones that we should really teach our physicians about. I think one of the challenges is that a lot of these agents like you can get in like GNC or other places, they're not regulated by the FDA, so most of us are not certain what the content is of some of those things, and often feel uncomfortable really giving informed information about them, which is very different than with the drugs that are FDA approved and those other things. Like, we have much more information. So it is an active area of research, because what we don't want to do is be withholding treatments that may be beneficial and complement traditional medicine, but we also don't want people doing something harmful, or we don't want people just wasting their money, because there are so many things out here. Take this and you'll wake up this and you'll lose 50 pounds, and we all know that is like very unlikely, and you only have to pay $20 and then $20 a month. Just be aware of things like that have not been studied, because we really just don't know with some of those things. What's that you were saying about the relationship with your doctor?
Get a good relationship with your doctor. It's like if you want $1 now,
Mhm.
you want to pay cinnamon on.
Right.
Get a good relationship where they're confident in you to know that you're not going to try to harm yourself. You're going to take their advice.
Right.
While we're there.
Right.
Also,
Right. Right. No. So her point is that if you have a good relationship with your doctor, you can at least like open the dialogue. So that's important in general. I should probably take a minute to talk about patient-provider relationships, because I think that's really important, particularly with diseases like diabetes and dementia and Alzheimer's disease. If you feel like your provider is not listening to you, or your family member who's ill, then you really should find another provider. And I'm speaking from personal experience, having just helped my mother deal with an illness in the last year, and taking her to 2 or 3 doctors where I could tell they were not hearing her. And if I had not been a physician, I shudder to think what could have happened, and how it took us to get to a 3rd doctor before we figured out what was going on and could get her treated. They sort of do pat the little old lady on the hand, like she is not a little old lady, she is running the discipleship ministry at our church. And I'm telling you, something is wrong. So if you're in a doctor-patient relationship where you feel like you're not being heard, your doctor may say to you, well, I don't think you should take that, but at least like you feel like you've had a chance to be participatory and engage with the doctor, then you're gonna all feel better about that decision. If they're like blowing you off and running in for 5 minutes, it's time to like look somewhere else, because you deserve better than that. You are in charge of your health care, and you are a part of that. It's a relationship. It is not a paternalistic one-way dialogue. So if you're sensing it's like that, it's time to sort of start looking around.
Finally given me an opportunity to put my question in directly to that. I am participating in Hopkins memory loss research. And I asked, what do I get out of it? I understand I have a PhD.
Right.
I understand research.
Sure.
The average person does not. But I said, they may need to study and wait until they have results. In the meantime, they know I have problems.
Right.
How about referral to doctors?
Right.
Or identifying the doctors in the community that would be useful.
Right.
And so in a community setting like this, I'm ready to answer the survey here, but I can't fill out what I like best and what I like least. It's a delightful experience. It's fun to be here. But the basics that I would like, you're not getting.
Right.
And I know you've got some reasons why you can't. You're not to diagnose or
Right.
provide any medical advice. But if I have to be my own advocate, how do I discover where to go?
Right.
That I can trust. And I'm concerned to say I've served on some hospital boards. We have a quality care commission. And our job is to check with our doctors to try to say, believe that the doctors we've employed are providing good care. What happens to those doctors who are in private offices
Yeah.
and people who know much or nothing
Yeah.
are
Yeah. Exposed to that.
enough for the street? But that's
But that was a very good point. So this is something that we wrestle with. I'm also a researcher. This is something we wrestle with, and so this is sort of how I've met my friend Inez. But so this is a very good point, because often when the community is engaging in a research study, you're right, you have a condition, you still want referral and information. And I think the way that research is moving is that instead of just you're the patient in the study, we're going to do whatever we're going to do, and then when the study's over, it's all over, and you go your own way, but you still got your issue. Now we're trying to do more community engaged research. So like in our Health Disparity Center, we have a community advisory board. So, our community advisors can give us information about where are the resources in the community. Our physicians know like where the referrals are within, our system. So like when I'm doing a study, for example, I study depression a lot. And so we actually built into our study referral for depression, because if we discovered it, and we discovered some things that were concerning, you know, we didn't want to just say, well, sorry about all that, and I hope you feel better, and we just send you on. So I think that in the context of the study, it's important to build in access to the community resources as well as you know, sort of referral within the system. So that addresses, and research is really moving that way. I mean, I personally think particularly to get minority participation in research, that's critical. Because my parents, I mean, I'm a researcher, and if the research network calls their phone, they won't even pick it up. Okay, so, you know, because there's some distrust, and I think as a community, we have reason to be distrustful. And so the way to sort of break down that barrier is to sort of have that community engagement piece. And then to address your second question about quality, I mean, this is a really hard issue because in the hospital there are regulations and guidelines. You know, we're on an electronic system now, so like Big Brother's watching, like they can see everything we do in terms of, you know, reconciling medication and making sure we've done particular things. But then what does happen in private practice? You know, what happens in the community where there's really no one watching? I mean, I think ultimately a lot of private offices are probably going to have to join some kind of accountable care organization where they would, you know, have a little bit more oversight. But this was the issue I had with my family, is that, you know, we're in a private office where there's nobody like, you know, reminding you actually have to examine the patient to come up with an answer. I mean, you know, so that's what I'm saying is like that is a challenge. I'm not sure what the right answer is. I don't know if any of you have any thoughts, but that's a challenge. So that's why I'm saying if you sense that thing, you leave the office and you sit in the car and you're staring and you're like, it just didn't quite feel right, then, you know, you can always get a second opinion. You know, don't worry about if the doctor's offended. I mean, you can get a second opinion. One more question. She said one more question. I'll ask over here. Sorry, go ahead. Mm-hmm. Right, the medicine. So the question is, can some people control their diabetes with diet? And if so, like who's eligible for that? So it can be controlled with diet. And the key is if your hemoglobin A1c is less than 7% and you can keep it there without medication, then you can control it with diet. So we really decide based on the hemoglobin A1c. Like if someone's first diagnosed and their A1c is say like 6.9, so they're not quite at 7, like we'll start out like, let's make the diet changes first. They can probably get it down a little lower. So it's sort of depends on where they start. And then you sort of have to ask the person, you know, how committed do they think they could be to sustaining the lifestyle changes? Because sometimes people are very honest. Look, you know, I travel with my job, I'm stressed out, I'm taking care of my mother and my teenage child, I am not going to have time to exercise. I put that person on a low dose of a medicine. So the person has to be honest. Do you think you're really going to be able to do this? Like, and how much can you do? I can only exercise 2 days a week, but I can't do 5. I mean, I think we have to allow the patient to be honest, and then we can figure out what might work for different people. I have some people like they're retired, they exercise 7 days a week, they bring me all these charts in and stuff with stuff. I mean, I'm like, wow. So it really depends upon where the person is and what they think their ability is going to be to sustain that long term. So, all right, thank you.